So let's get started. And everyone that's supposed to be here is here. So turn our cameras. Just three of us today. Welcome to the October 18th, 2022 Licensing Committee meeting. My name is Song Oh, Chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we are accepting public comment. I've advised the meeting moderator to allot 3 minutes to each individual providing comments. This approach is necessary to facilitate this meeting and ensure the committee has the opportunity to complete its necessary business. I would like to staff moderating the meeting to provide general instructions to members of the public participating via WebEx. Moderator?
Thank you, Mr. Chair. Before we get started, I would like to remind committee members and senior staff who are not speaking to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will interject with a brief friendly reminder or simply mute the microphones. To facilitate public comment, we will be utilizing the WebEx question and answer feature, also referred to as the Q&A panel. When the chair reaches a point in the agenda at which public comment is appropriate, public comment will be requested. Please note that the Q&A feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. Once given permission to unmute, the member of the public may unmute themselves and verbally state their comment. The Q&A feature is not to be used for typing out questions or for committee members to communicate with one another. And with that, I return the floor back to you, Mr. Chair.
Thank you, Tricia. Thank you. I'd like to take a roll call to establish a quorum. Members, as I call your name, please remember to open your line before speaking. Jig Patel?
Present, licensing member.
Good morning, Jig. Indira is not joining today. Jesse Crowley?
Present, licensing member.
Thank you, Jesse. And Jason is not joining either today, and I'm here. The quorum has been established. Members, we have a full agenda for our meeting today, including consideration of a number of legislative proposals. I truly appreciate all of your time and commitment to the board and California consumers. I ask everyone participating today to be respectful of the work before the committee today. We encourage participation by members of the public throughout our meetings at appropriate times. We respectfully request that when comments are provided, they're done so in a professional manner consistent with how the committee conducts its business. Before I open up for public comment, I would like to advise everyone that the issues regarding pharmacy ownership and prohibitions discussed during public comment during our last meeting is still under consideration. After staff have completed their assessment of the issue, it will be brought back to the committee for consideration. I will now open the meeting for public comments for items not on the agenda. I would like to remind members of the public that you're not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take action on these items except to decide whether to place an item for a future agenda. Members, following review of the public comments for this agenda item, I will ask members to comment on what, if any, item should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Moderator, we're ready for public comment for individuals participating via WebEx.
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. Moving on to the next agenda, agenda item 3, approval of July 18th, 2022 committee meeting minutes. Included in the meeting materials is draft minutes from the committee's July 18th, 2022 meeting. As we begin, I'll ask members if you have any questions or comments and also if anyone would like to make a motion. Since it's just three of us, we have not many options. So if you guys could just hopefully be cool making motions, and I'm more than happy to make motions as well. So go right ahead. Anyone?
Hi, this is Jesse. I can make the motion to approve the minutes.
Thank you, Jesse.
I'll second that.
Thank you, Jake. With the motion and second on the floor, I'll now open the discussion for public comment on the July 18th, 2022 draft minutes. Moderator, we are ready for public comment.
Thank you. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and send it to all panelists, or simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no request for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha. With the motion and
You're
second and public comment, we'll take a roll call vote. Jake, how do you vote?
Yes.
Thank you, Jake. And Jesse, how do you vote?
Yes.
Thank you. And I vote yes, the motion passes. Moving on to the next agenda item 4, discussion and consideration of possible statutory proposal to expand current pharmacy technicians' authorized duties, current pharmacist to pharmacy technician ratio, and possible changes. Members, today we have the opportunity to continue our discussion on pharmacy technicians, including authorized duties, technician ratios, and possible changes. And for the first time, it's been a long road to get here to discuss a possible statutory authority. This proposal was drafted after considerable opportunities for participation and discussion by both members and stakeholders. I want to publicly acknowledge and thank everyone, members and stakeholders, for your robust engagement, and also thanks to our previous chair, Debbie Veal, who is no longer with us, but all the effort. I really appreciate it. I recognize that sometimes policy changes do not move as quickly as some would like. The deliberative and thoughtful process used in the board's efforts is necessary to ensure actions taken by the board and consistent with the board's consumer protection mandate. As a reminder, following initial discussions by the committee, members convene a series of listening sessions for pharmacists and pharmacy technicians. I myself was there for all sessions, and in addition to the listening sessions, the board also released surveys as another means to solicit feedback. In April, we convened a Pharmacy Technicians Summit, where as a committee, we discussed the results of the listening sessions and surveys, information at the national level, and research on various related topics. As detailed in the meeting materials during our discussion in April, we reached consensus on some areas, including some possible new duties for pharmacy technicians, including authority to administer vaccination, authority to receive verbal prescriptions and transfers, and authority to perform some aspects of CLIA-waived testing. More recently, during the July committee meeting, we continued our discussion by considering the policy questions detailed in the report. Members, attachment 2 includes a copy of the statutory proposal prepared by staff following our policy discussions. I have reviewed the proposal and believe it is appropriate and consistent with our discussions, balancing all stakeholders' thoughts. I believe this proposal serves as a complement to activities underway in other committees, including the Medication Error Reduction and Workforce Committee as well. Members, appreciate your comments on the draft proposal. I hope, I'm sure we have some thoughts on this, so I'll just call upon anyone wants to go first. Please feel free to speak up.
Good morning, this is Jig.
Hi,
First
Jig.
off, any attendees that are pharmacy technicians, happy Pharmacy Technician Day. President No, can be a better day to discuss this expansion of current roles for pharmacy technicians to celebrate National Pharmacy Technician Day. Just had one, like you said, it was a long road. I think we're going in the right direction and going to empower our pharmacy technicians to contribute more to the consumers with the role expansion. So I'm very happy about that. I just had a comment about the technician ratio. In the verbiage, it still remains at one. And any thoughts on taking it to the board to at least making it two for pharmacist? I feel that it's very difficult in a lot of hospital settings to accomplish what they are supposed to, well, as far as the workload is concerned, and that various different pharmacists that work in hospital settings feel that that would be really helpful in workforce and also in some community settings. So um, I was going to request if we could change that to two and take it to board for full board approval.
And can you clarify Jig's comment? Great thought, Jig. I thought it is um, changing to two only for vaccination activities. Or are you saying, Jig, for everything in general?
Yes, I was thinking in everything in general because I was reading it, and one of the things that stands out is, you know, um, and just looking at different settings, right, and inpatient hospitals especially, and I they are not doing vaccinations there, and this change is not going to help some of the settings, and I feel that we should have that where a pharmacist can oversee two technicians regardless of what duties they do, as far as they are doing license authorized duties.
Gotcha. Okay. We'll have to think about that one. Okay. And Jesse, your thoughts?
Yeah, I remember, I think similarly to you, President O, that we had discussed expanding the role specifically when it came to immunizations, which I do think is appropriate. I think there, at least in terms of a community setting, there needs to be another technician available in the pharmacy to continue performing duties like filling prescriptions while a technician is administering vaccinations. In terms of what Jig is saying, I would be interested in hearing feedback from hospital pharmacists. If there's anyone on, please make public comment when it's
Yeah.
appropriate to see. I guess if you feel as though you're able to supervise more than one technician at once. I do remember at our last meeting we did have someone chime in from the retail sector, saying that that they're a little bit nervous about how they're supposed to supervise more than one technician, specifically with with expanded roles that you know sometimes have potentially um, emergency activities that they have to perform. So I don't know if you have any more insight, President O.
And I'm gonna go to you. If you could just speak on the thoughts shared by Jig and Jesse on the ratio and inpatient settings.
Hi, thank you. Yeah, I believe that the ratio for community currently is 1-to-1 for the first pharmacist, and then when a second pharmacist joins, it's 1-to-2. I believe that's the state of the law right now with respect to community. I believe in the inpatient setting, the current ratio is 1-to-2.
That was my understanding as well. Okay. All righty. So I think with this, I mean, it's just I think the ratio is a beast that we need to tackle on its own. I would prefer that we just do step by step, because I think we've all talked about how we don't want to touch the beehives too much. So if it's okay, I think if we can go in a direction of just going with this first and then hoping we can tackle it later on. But I'm also looking forward to hearing some public comment as well. So anyone, I don't know if you want to make a motion and then we can see where that comes to. We can try there. So
I think that's a good idea, Sung. I did have one question first of all, thank you, staff, for putting this all together. I think you did an excellent job. I think you captured everything that we've discussed at our previous meetings. The one question I had, and maybe someone can help clarify, did we confirm whether the expansion would apply to all CLIA wave testing for technicians, or was it only going to be specific ones?
I'm gonna,
Uh,
yeah,
so-
go ahead.
Yeah, so Jesse, I think that it would probably be determined at the store level and by the PIC. I think that the practice settings vary a little bit, so I think it would probably depend on the policies and procedures of the pharmacy.
Okay, thank you, Anne, for the clarification.
Yeah. Can I also just chime in to make sure that council agrees with me? Sorry.
Hi, this is Eileen Smiley, the board counsel, and I was looking at 4115, and the way that that's phrased is that it would apply to all CLIA wave tests. I think there would be other regs that talk about the pharmacy has got to have policies and procedures establishing, you know, how these functions would be done, but that wouldn't be in, it doesn't appear to be in the statutory proposal, but I think those are in the regs, but that's something we could look to clarify.
I would imagine that in an essence, again, I'm not a lawyer. I say that every time I say anything, it seems like I feel like, but I would imagine that what a pharmacy is allowed to do would be what is allowed for technician to do. So already pharmacists, what they're not allowed to do, I would imagine the technicians would not be allowed to do. Granted, this could be a little further discussion of if is this mean that I don't want to actually say anything further on that than that. So that's what I would imagine, but I guess there could be debate about it.
Right, and this is Eileen again, President O. I just wanted to state, I think what the staff is doing here, we need to get the statutory authorization, and some of the particulars with respect to how that could be administered would be handled in the changes to the regs that govern these sections. But the first part is to get, you know, the statutory authority for pharmacy technicians to be able to do this, and then maybe we can address some of the other things, for instance, the PIC having the via the reg. So the first starting point is, does the board feel this statutory proposal would authorize the technicians to do what they want the technicians to be able to do? And then we can work on the particulars when we update the regulations that also govern in this area.
If I could just jump in just really fast, just in case it's helpful. So the authority that that we're, you know, seeking potentially to establish here is just the specimen collection. So they wouldn't be able to, you know, initiate or anything else, right? Pharmacist involvement is absolutely still there, depending on, you know, how the pharmacy operationalizes. And I think that like the overall kind of policy concept that the committee was looking at was kind of like delegating the determination to the PIC of those authorities. So if we feel like maybe the language in the proposed B1 needs to be further refined, because it talks about the PIC, you know, is determining what of those, you know, functions can be performed by the tech. So if we, you know, another possible, if we feel like that's maybe not tight enough language to get to that, that might be an area to, I don't know, further refine. Thank you. Sorry for jumping in again.
Not at all, and thank you. Again, this is, you know, we're not the legislators, so this is just a starting point. So it's, you know, just to get the ball rolling on it. And so, yeah,
I
go
do
ahead,
have a follow-up question. Sorry, Sung. I can't remember where we left off in terms of if we had a consensus whether or not technicians would need to be nationally certified in order to perform these sort of testing and vaccinations and CEs. Is that something that would also be updated once the regulation is updated? Maybe that's a question for council or Anne.
If I can jump in, I apologize. Sorry. So I think that as proposed, if the technician is going to be doing those expanded duties, there is the requirement to be certified in B3. And then in proposed B4 draws in those requirements for training for the vaccine related items. And again, maybe the language needs to be tightened, but that's kind of where it is.
So they
Got it.
can,
Okay. So sorry, I was confused because I think when I read it, I interpreted it as like the on-hand training for each individual duty that they're performing. So like the vaccination certification. But I guess what I was referring to is just a national technician certification. So I don't know if we're referring to the same thing here, and maybe someone else can chime in. I know. Sorry, I cut you off, Jake.
no, that's okay, Jesse. I mean, I was just going to comment what you mentioned. I think it's not like if you're PTCB certified or any other accredited certification that a tech can get. It was specific to what you were referring to, immunization training or any point of care testing. They're all specific tests, and there's little training for each one of them. So if they are doing, whatever training, then there will be very specific certification for each one of them. Because I doubt that PTCB even covers immunization training. So if that section that we have, I think that covers.
Right. Yeah. I guess I feel pretty strongly that if technicians are going to continue doing these roles regularly, that there should be additional certification on top of just the regular training and consideration of the CE requirements as well.
I'm sorry to jump in. So I'm based on the conversation, I'm wondering if B3 needs to be, based on the committee's. So B3 talks about the certification. So they have to be certified and then maintain it. And that the two that are recognized in the section there are PTCB and the accept one. And so we were trying to get to the certification initially and then maintaining that certification, which then kind of pulls in that CE requirement. But I'm not quite sure that maybe the language then is what you guys were looking for. And so I guess my question would be, are you also asking for the board to require CE or CE through the certification?
I think I would have to think about that. Maybe Sung, I'm sorry if I cut you off. Maybe you have some more insight on that.
Oh no, I'm really on that one. I don't have any strong feelings personally. I think that it's.
Does anyone know what the CE requirements currently are for those certification programs? I'm not familiar with them.
It's similar to a pharmacist, but go ahead. Yeah, anyone who knows better.
Yeah, it's 20 to 30 hours every 2 years to maintain PTCB certification and renewal.
Thank you. Oh, in that case, I do think that it would be appropriate to just do what they require rather than having to have us update our regulations.
Yeah, and Jesse, here's where it gets complex, right? If you want to add that layer of PTCB, there are already immunization trained technicians out there that are not PTCB certified, but they did the training and are taking care of COVID vaccines right now. So how do we backpedal and add that layer on it? So I think this suffices, but that's my thought.
Yeah, my thought on it is that, both flu season and COVID season come in waves. So depending on where everything lands, there could be several months in which a technician isn't actually practicing with vaccinations or administering that frequently. And so that's kind of why I feel pretty strongly about it. But I do think that that the 20 to 30 hours already required is sufficient.
All right, I'll
Oh.
make a motion. Or
All
should we
right.
go for public comment?
Oh, no. Go ahead, Jake.
All right, I'll make a motion to for agenda item 4, discussion and consideration of statutory change proposal to amend Business and Professions Code 4115 as presented.
Thank you, Jake.
I'll second that.
Thank you, Jesse. All right. And with that, we'll go to public comment. I think this one will have a lot of public comment, so we'll see where we land on it after.
All right, thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. And just a reminder, you'll have 3 minutes. I'll give you a 10-second warning. And let's see. So our first request for comment is from Mark Johnson. And Mark, you should be able to unmute yourself. And Mark, you're unmuted.
Oh, thank you. This is Mark Johnston, representing CBS Health Today. I appreciate the extra minute to 3 minutes. Thank you very much for that. Starting with B, the federal government allows technicians to engage in performing CLIA-waived tests. The way it works is that the feds mandate a lab director. The lab director federally may be a pharmacist, and now thankfully in California may be a pharmacist too. And then the lab director determines what activities the folks under them can perform. So a state like California, who with this proposal would limit that performance to specimen collection, would be more restrictive than federal law. The overwhelming majority of the states follow federal law and allow the lab director, in this case the PIC, to determine who can perform. Doesn't even have to be a technician federally, but if it is a technician and a certified technician, limiting to collection of the specimen and not being able to take the specimen and stick it into the testing device, for example, is much more restrictive than federal law and what most states do. So I'd ask you to reconsider B and give that authority to the PIC to determine who is trained appropriately to perform additional functions of the test. As I go down to number 4, I see that ACPE approved immunization training is required if this technician is going to receive verbal prescriptions, do CLIA-waived testing, receive transfers, and accept clarifications. So I wonder why a technician would have to be trained in immunizations if the only expanded duties they're going to do are these other expanded duties in the list besides immunization. Perhaps that needs to be cleaned up. Also, I see, going back to B, they're able to receive prescription transfers. Would they be able to initiate prescription transfers? As I read this, they would only be able to be on one end of the call, not on the initiation end of the call. So perhaps that's worthy of discussion. And then as I go down finally to G1, where it talks about the ratio, so the way this is written, one person can do, count and pour, the traditional technician duties in California only. And then another technician would be able to do the expanded duties like immunization and whatnot.
Seconds.
But if there is no immunizations to do, the second technician would be standing around and not able to help with the counting and pouring. So.
All right, and time is up for that. So our next request for comment is from Lindsay Gulaham. And Lindsay, I'll let you know when you can unmute. So Lindsay, you should be able to unmute. There you go. And Lindsay, you're unmuted. And Lindsay, we are not able to hear you. You are unmuted. So you might want to go to audio and video and choose call in for your audio. what I'll do is I'll mute you for now and we'll come back to you. So our next comment is request is from S. Hill. And S. Hill, you should be able to unmute yourself.
Can you hear me?
Yes.
Great, thank you. Thank you much for taking my comment. My comment is really going back to what Mr. Patil had said about the inpatient pharmacy ratio. While you were having your discussion, I did pull up 4115, looking at the inpatient pharmacy ratio, and it looks like it is 1 for the first and 2 thereafter, unless you can correct me to the correct board regulation. But I would hope that you would consider reviewing that technician ratio or pharmacist ratio for inpatient work, just due to the nature of inpatient pharmacy work has drastically changed over, say, the last 5 to 10 years, with CPOE, electronic medical records kind of being proliferative throughout, tons of automation and safety procedures put in place with barcode scanning and a lot of type of other safety things that are going on there. And the fact that with CPOE, technicians aren't really doing clerical work in the same way as they used to. So there's a lot of different changes in inpatient pharmacy from a long time ago with different types of activities. So I would recommend, or I request, some reconsideration, maybe at a future date, of the inpatient pharmacy technician ratio. Thank you very much.
All right, our next request for comment is from Keith Yoshizuka. And Keith, I'll let you know when you can unmute yourself. So Keith, you should be able to unmute yourself. There you go.
Oops, I'm muted. What else?
We can hear you, Keith.
Oh, okay. Thank you very much for the opportunity. Keith Yoshizuga with the California Society of Health System Pharmacists. We wholly support the expansion of the technician duties. If I may, in terms of the CLIA-waive testing, in fact, all of the duties, rather than being specific, might it be advantageous to just use the standard board language and say that the technician may perform the non-discretionary tasks. So that would include doing the mechanical test of, adding the diluent and whatever performing, but they would not be able to interpret the test, that they would have to show to the pharmacist to interpret. I think that would avoid a lot of the complications that I'm hearing. Thank you very much.
All right, the next request for comment is from Jassy Gruel. And Jassy, you should be able to unmute yourself. And Jassy, you're unmuted.
Wonderful. Good morning, Chair and committee members. I'm going to try to keep it to 3 minutes, but have a lengthy list of comments that I'm happy to also submit via writing. First, I wanted to express our support of a minimum staffing ratio. We think it's really important to ensure that if a pharmacist is lucky to have a technician working with them, that they don't lose that technician to perform these other ancillary services like vaccinations. So really support that minimum staffing language to ensure that there is a technician that is trained working with a pharmacist in those duties. However, we do want to express some concerns with some of the other language. Our first concern is how expansive the vaccine authority is. There are certain vaccines like monkeypox that required additional pharmacist training. And so in those situations, what type of additional training will technicians be receiving? Are they competent enough to be able to perform various different types of vaccine techniques? So I think just putting that out there as a point of discussion. I also believe that there needs to be clarity in what type of oversight that the pharmacist will be playing over the 2 technicians. Without this clarity, we are worried about pharmacists being penalized in the future without knowing what sort of supervision they were supposed to provide. A technician who might be in a closed space with the door shut, providing a service to a patient. So additional clarity there would be good. Also, it's important that when a pharmacist is on their 10-minute break or their lunch break, that technicians don't perform any of these other services like vaccinations. Pharmacists right now are reporting that they aren't able to actually take those breaks because of vaccine appointments being scheduled to their 10-minute breaks and their lunch breaks. So they're just working back-to-back 12-hour shifts for a couple days in a row. And when those breaks are happening, if technicians are also able to take those breaks at the same time, it ensures that if a patient's having an adverse reaction and the pharmacist isn't nearby, that there is somebody, just somebody there to make sure that the liability doesn't fall on the pharmacist or the PIC when technicians are performing those duties on their 10-minute breaks and their lunch breaks. Also, we have concerns with only the PIC being able to determine if a tech can do vaccinations. Sometimes the PIC isn't there and the pharmacist does work more closely with the technician. So expanding that to the pharmacist is also very important because they will be able to also determine, is a technician competent enough to be able to perform all of these trainings. And then there's also needs to be additional clarity around who is competent and what competency means in these additional expansive roles. With that, I think it's also important to ensure that there is a rebuttable presumption for retaliation to ensure that PICs and pharmacists who exercise their duty in one of the subdivisions, sorry, my dog has a squeaker toy right behind me.
10 seconds.
Is not being held liable if, there's a rebuttable presumption so that if anything does go wrong, that the
And the time was up, so we're going to Paul Sabatini. Paul, you should be able to unmute yourself. There you go, you're unmuted.
I am past president of the Pharmacy Technician Executive Leadership for CSHP, past president of the SIG Committee for CPHA, and the original author of the policy for pharmacy technicians to vaccinate on a regular basis. That was supported by California Pharmacists Association. And I just have a clarifying question about the issue with being nationally certified to perform the extended duties. I'm a little curious as to why that language was included when it's not mandatory for initial applicants to be certified as pharmacy technicians. So if I could get some clarification on that, I really appreciate it. But I do support the extended duties, of course.
All right, and now we're going to return to Lindsay Gulaham. See if Lindsay can be heard this time. So Lindsay, you are unmuted. And Lindsay, we cannot hear you. So again, you might, okay. Looks like Paul Sabatini has his hand up. He did not use his full 3 minutes. Oh, I think that was a mistake. Okay. And Lindsay, I don't think we're going to be able to hear Lindsay unless they call in. John Gray has a comment. John, you should be able to unmute yourself. John Gray.
Hi there. Good morning. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. I just want to provide one kind of quick comment on the draft statutory language, and that is that I just want to ask the members of the committee if they think that the ratio language in the proposed 4115G clearly expresses the committee and the board's intent. Specifically based on the proposed language and on the meeting material notes up kind of in the front of the meeting material, I think the intent is that when a pharmacy technician is performing the new duties described in 4115B, then there must also be a technician performing available or scheduled to perform the duties in 4115A. And therefore the allowable ratio when there is one pharmacist in that particular case, and actually the required ratio is 1 to 2. It took me quite a while to figure that out, reading the statutory language as well as the meeting notes, as I said. So I just wonder if others on the committee also had difficulty parsing that, or if other members of the public might have difficulty parsing that, if this is the the statutory language that ultimately gets adopted. One way, if the board wants, if the committee wants to tighten that language, maybe to consider modifying 4115G, where the new sentence that says a pharmacy with only one pharmacist shall have not more than one pharmacy technician performing the tasks specified in subdivision B, you could consider adding something like the phrase, and must concomitantly have one pharmacy technician scheduled to perform the tasks provided in subdivision A, to make it clear that it's not, the first two sentences of 4115G are not an either or, G1, excuse me, are not an either or, but are an and. You must have one, you may have one technician performing the duties in B, but you must also have one pharmacy technician scheduled to perform the duties in A. It took me, again, I'm belaboring this point, but it did take me quite a while to arrive at the conclusion that that's the board's intent. Thank you very much for the opportunity to provide feedback on the draft statutory proposal.
All right, this is the moderator, and Lindsay has changed the audio, so we'll try Lindsay one more time. And Lindsay, you are unmuted. And Lindsay, we still can't hear you. So again, it looks like you're using the computer for your audio. I do recommend calling in. So you would just go to the top of your computer, choose audio and video, and select the call-in feature. And with that, that is the end of requests for comments. Shall I close the Q&A panel?
Yes, Tricia, thank you. I'm gonna try to see if Lindsay, if you can just call in and let us know. I think you can comment or something on there. I want to make sure that everyone who would like to say something has an opportunity to say something. So
I think I just saw another person request comment. Is that someone new?
I can reopen the Q&A panel. Hold on. Yes, that is someone new. So thank you. That's Sandra. Yes, thank you very much. Sandra Gukian. So Sandra, you should be able to unmute yourself. And you're unmuted.
Association of Chain Drugstores. I'd be interested in the board's discussion around this issue related to access and social determinants of care. How will this proposal affect the most vulnerable residents of California who may have difficulty in accessing healthcare services, and pharmacies may be their only point of access? How would this proposal impact those patient populations in the state of California?
Okay, and I see Lindsay is gamely trying another time, so let me, okay, Lindsay, it looks like you're still hooked up to your computer audio, not by phone, but we'll give you one more try. Okay, Lindsay, you are unmuted. And you just muted yourself, so let me try that one more time. Okay, so Lindsay, you're unmuted. And we cannot hear you. So again,
because her microphone thing is like going off on the low.
Exactly. Right. So that's why probably calling in would be better. All right. Okay. So they are going to call in. Do you want to wait a moment to give them a chance to call in?
Yeah, of course.
Okay. I can tell when they've called in because there'll be an icon next to their name of a phone. So
Right, yep. This is when you should have an elevator music ready, Trisha. Dun, dun,
I
dun,
I
dun,
know, or some just nice, easy listening jazz. Yeah.
right? Yeah, there you go.
Duh.
I'm sorry to interrupt, but just because we have a little bit of downtime, there's been quite a bit of discussion about the ratio in the inpatient setting.
Oh,
So
thank you,
I
Ann.
just
I was
want,
gonna put you on the spot
yeah,
one more time, so I'm glad you are putting your spot on yourself. So go ahead. Thank you.
yeah. I would suggest it might be helpful for people to look at 1793.7. I believe F is where it talks about that higher ratio for the preparation of a prescription for an inpatient of a licensed healthcare facility, et cetera. So that's in, like I said, CCR 1793.7 and then sub F. Thank you.
Thank
Sorry
you.
for the interruption.
I noticed our vice chair, Maria, is also in attendance. I was about to bring her in here to just have her say something about it, but thank you, Ann, for speaking on that. So, all right, do we have Lindsay yet?
Lindsay has logged out off the meeting.
Oh,
So I
she's
don't-
probably gonna try to just call in.
Exactly.
Okay.
Yes.
I guess while we're waiting, we can just make sure no one else has anything to say. I just want to confirm on the public comment. Anyone wants to speak, please speak.
I see S Hill says thanks. I will review.
Oh, great. Thank you, Anne.
So, Sang, I know that Ann talked about 1793.7. Just for clarification, does that mean that in an inpatient setting, the first pharmacist that's working can oversee only one, and then as written right now, and when the second pharmacist is present, there can be total of three?
Oh, I've learned my lessons to not try to answer that kind of question in a public meeting. So I'm gonna put Anne on the spot there.
Yeah. So if it's okay, I'll just read the language. So it says, so I'm in that regulation section, and it says, for the preparation of a prescription for an inpatient of a licensed health facility and for a patient of a licensed home health agency, the ratio shall not be less than one pharmacist on duty for a total of 2 pharmacy technicians on duty. And then it continues on, but I think that that's the sentence, Jake, that gets to your question.
This is the moderator. We have 2 call-in users. If call-in user is Lindsay, you could press *3 to raise your hand, and that way I'll know it's you. Otherwise, I do not see Lindsay.
Eileen, is there any way we could take public? I mean, I guess it probably won't work. We probably have to either wait and take public comment here and have her speak here. We can't have her speak at next agenda item or anything, right?
It would be kind of hard because if the board votes on something, then she speaks later and then you want to re-vote, you'd open it up. So I don't know if the board members want to have any discussion based on the public comment. Maybe that's the way we, because if you do, then we may have to open it up for public comment anyway, but it's kind of hard to vote on something and then we allow her to speak, then we'll just be going back to public comment after that if the committee wants to consider that. So I don't know if the committee members wanted to have any discussion about any of the matters raised so far in public comment, and if so, then we can give her a chance to call in. But that's up to you, President O.
Okay, I'm not changing any stance on the issue at this point. I'm not sure.
This is Jessie. I would be interested in having some discussion on public comment. I don't know if Jig also feels similarly.
Go ahead, Jessie. We'll just.
So a couple of the questions were in regards to certification nationally, and why someone would be, or why we're asking for someone to be required to if they aren't for initial application. And I think part of my understanding, and someone please correct me if I'm wrong, is that a lot of the pharmacists during the Pharmacy Technician Summit reported inconsistency with training of technicians because we don't have a consistent requirement. So I think this creates a sort of consistency for those who are performing advanced duties. From my understanding anyway. The inpatient ratio we've already talked about. Let me see. I also, just echoing someone's comment about a staff pharmacist being able to determine if they feel comfortable or if it's appropriate for a technician to administer vaccines. I do agree with that the pharmacist who's actually on duty should be able to make that determination. I'm not sure if extra language is actually required or if that's also just kind of given in what we have in regulation as it stands. So maybe staff or Eileen can help us with clarification on that. And I do see, I agree with the little bit of confusion on the language in terms of when it becomes a ratio of 1 to 2 technicians. It's a little, I see where the confusion lies in rereading it. I agree that there's a little confusion in that portion. What section was that? Let me pull that up.
I think you're referring to G number.
Yes, thank you, Jig. Yeah.
Number
So I would be open to adding like an additional section for clarification if the other committee members are open to that as well.
I feel that there's some clarification needed in G2.
Okay.
15 G2. So that
yeah.
it's to make it a little bit more clear. No other changes, just to make it clear.
And do you have a suggestion for us? I know you're not a lawyer. Sorry. Don't
So,
make you a lawyer.
Yeah, so I'm not a lawyer. I think that some of the language potentially from Dr. Gray might provide a pathway if you felt comfortable with such an approach. Could I just ask a quick clarification from Member Patel? When you said G2, did you mean the section of G as well, or did you mean the citation G2 of the law? And I apologize. Just want to make sure that I'm understanding what you're referencing. I think G, like the law section G2, talks about specifically the filling of prescriptions in an inpatient. So I'm assuming it's G1, and you were saying 2 as in also, but I wanted to just make sure that I'm understanding that comment.
No problem. Yeah, I was talking about the paragraph that starts with the board may adopt regulations establishing the ratio of pharmacy technicians performing the task specified in subdivision, and then there's A, to pharmacists applicable to the filling of prescriptions of an inpatient of a licensed health facility, and then continues to any ratio established by the board pursuant to this subdivision shall allow at a minimum at least one pharmacy technicians for a single pharmacist in a pharmacy and two for each additional pharmacist. That sentence needs to be further clarification so that it's easily interpretable.
That we're not changing that though, isn't it? I thought we were talking about just G1, a pharmacy with only one pharmacist shall have not more than one pharmacy technician performing the tasks specified in subdivision B. I thought that's where we're trying to clarify.
Yeah, that's the point that I was referring to. I think that subsection, the G2, may actually be the same language that exists in
It is.
that.
It is.
Okay.
Only underlined is what's changed.
Yeah, okay. Yeah, so I was specifically referring to the G1 section of pharmacy with one pharmacist shall have not more than one pharmacy technician performing tasks specified. Because I do see where there's a bit of disconnect between that first sentence and that second sentence. And I could see where that would be confusing for a pharmacist reading it to kind of determine the ratio.
This is the moderator, and Lindsay now has a headset, so we'll give her a chance.
All right, Lindsay.
Me?
Yes,
yeah,
we
yeah.
can.
Geez, thank you so much. And I'm so sorry. I don't know. I was on my phone, but it wasn't working for some reason.
Buy us on lunch. Just kidding, Lindsay. Go ahead.
Apologies. Okay, and I got kicked off, so I missed some of the discussion. So apologies if some of my comments were already addressed or discussed. But this is Lindsay Goldhorn with the California Retailers Association and National Association of Chain Drugstores, and I'm speaking just generally about this proposal. Just want to say that we really appreciate the committee's work on this. I know it's been a long road and appreciate board staff work in drafting this. Absolutely support the expansion of tech duties, including permanent authorization for immunizations. And while we are supportive of these expanded duties, we think parts of this are limiting and could actually place a greater burden on the workforce in the pharmacy than what exists currently. Like to echo the comments of my colleague Mark Johnston with CVS regarding the ratio. I think our two primary concerns with it, if I'm reading it correctly, is that the proposal only expands the ratio by one technician and only for certain duties, and that it requires pharmacies to have an additional tech in the pharmacy in order for the other technician to perform the additional duties. So again, I appreciate the work that has gone into this, and I think it's a step in the right direction. Agree with board member Patel's earlier comments. I think any expansion should not be limited to certain duties. We think a true expansion, whatever the number ends up being, that is not tied to specific duties, is a solution that will protect consumers while reducing workforce pressure. And also think that the ratio piece of this is probably, I don't know if it should be a separate discussion and maybe something that we can, or the board can come back to, but duties certainly support the expansion of duties, but think that the ratio needs more work. So again, appreciate all the work the board has put into this and look forward to the continued discussions on this. And thanks again for your patience with me.
Thank you, Lindsay. Okay, with that, any other public comments?
I do not see any more. Shall I close the Q&A panel?
Yes, please.
Okay, it's closed.
Okay, all righty. I think we were just talking about G. I know that this was pretty deliberative, all the things in here based on a long discussion, surveys, committee meetings, listening sessions, our discussions, and all the stakeholders. We were really trying hard to balance everything. So I know that sometimes it may not be where everything we want is in here, but it's just sometimes we are trying to balance everything. So with that, I'm gonna just go back to our committee members as continuing our discussion. Should we try to add another language in there? And also wondering if we should add a little motion to say something along the line, we'll work with the chair of the committee or president or something to work with the legislature. I don't know if that motion's necessary in there, Anne, if it is, or if it's useful, just because it's going to be a legislative proposal. I know we've had some challenges to try to navigate through that. So open it up to you guys again for your thoughts.
Is it back to Ann or?
All of us, Jig, Ann, and Jesse.
And does it require, the motion require for us to say that specifically, to give it to executive officer and the
I'm not sure
legislature? That's not.
What do you think, Ann? Do you think that that's necessary? I mean, I guess we already have a policy statement in our board manual to work with the president. So.
Okay.
President, hi, this is Eileen. At this point, I don't think it's necessary to be in the motion. I think what this committee is doing, the board, if it passes, or accepts whatever the licensing committee comes up with, maybe they can add that into their motion. But at this point, I think the motion that would be before this committee would be what it's going to send to the board to pursue a statutory proposal to amend Business and Professions Code Section 4115, either as presented or as discussed during the meeting. And then when the board takes up whatever the committee's action is, then maybe that type of language can be added to the board motion. Does that make sense?
Yeah.
Okay. All right. So we can just maintain our motion as we stand, or we could amend it slightly if you would like. But again, this is just a very starting point of a long road ahead. So.
Hey, Sung, before we make a motion, I did have one last public comment I wanted to address, which was a very important question about how we think this will affect social determinant of health and access to care. And I just want to point out that part of the reason why we discussed this expansion of the technician ratio, specifically when it comes to the vaccine administration and expanded duties, because a lot of pharmacists did feel like they were juggling too much, but also may not be able to supervise multiple technicians doing things. And so if we are taking a technician from workflow, we don't want it to be that a pharmacist is multitasking and potentially increasing the risk of medication error. So all of this is considering the workforce survey.
Right,
and I would also be curious, I don't even know if we have this data, but I would be interested to see if there is any data on where these pharmacies are located that provide expanded services, whether they're concentrated in a specific area, when we do really need them in healthcare desert. So I think that is something to consider. I don't think it's necessarily something that the statute can necessarily address, but I think it is an important thing to discuss for future.
Thank you. Okay, with that, we have motion. And public comment, we can go for a vote if you all are okay with it. Go ahead, Ann.
I apologize. So we're keeping the motion as the language as presented. Is that correct?
I'm okay with that at this point.
Yes.
Okay, and President, thank you, Ann, for raising that, because I wanted to check, because Member Crawley was the second on the motion, but you had also indicated in comments that you also wanted maybe the pharmacist, not just the PIC, to be able to make the delegation. That's not currently in the proposed statute that you seconded the motion for. So I just want to make sure that you're still good with the second on Member Patel's motion to present the statutory proposal as presented.
I guess maybe this is a good question for you, Eileen. Given the proposed language that we already have in the regulations we have, would it be would it still be up to the pharmacist on duty to decide whether or not the technician they're working with that day is able to perform those duties? Or does this language essentially put it all on the pharmacist in charge, regardless if they're the ones on duty?
I feel like that goes back to another section of the law, but I don't know, maybe I'm incorrect, but I always felt like pharmacist on duty has the authority to determine what goes on in that pharmacy, whether that's safe or not to be determined by that pharmacist. I'm not sure if that's backed by law, maybe not, but
I think so, Sung. I think when the immunization for COVID vaccines was allowed, in that section, it does say that if the pharmacist allows that pharmacy technician to immunize.
Got it. And in that case, I would want to add similar language to this to include that.
It's already there, Jesse. That's what I was trying to tell. Like, a technician cannot immunize unless a pharmacist allows them to do such, as far as I know. But Eileen,
But I thought we were saying that language exists in the waiver. Right? Not so what we're looking for some permanent statute. Maybe Eileen can provide some clarification.
Hi, this is Eileen Smiley. I was just trying to work through what I'm a bit concerned about. Maybe what we need to look at is, we do have that in the waiver that the pharmacist is delegating the duty, these duties. And what I'm concerned about is if we do the 4115B1 saying it's the pharmacist in charge of the pharmacy at which the tasks are being performed is deemed the pharmacy technician competent, that there could be a disconnect. So maybe it's something where we amend that language where, that there's a delegation by the pharmacist. It's just, that's what I'm concerned about. I'd have to go back through the waiver, but I think the way it's currently drafted in B1 with the pharmacist in charge, it's not, you could have a situation where the pharmacist in charge deems them competent, but the pharmacist who is actually on duty and supervising may not. But I wanted to check first with Anne too to see if she had looked at the waiver language with respect to drafting this as well.
So I can't speak to the legal piece of it.
Don't we have? Okay, go ahead, Anne.
So in 4115 F3, which I believe would still be, well, Eileen will have to tell us if it's still relevant. It says a pharmacist scheduled to supervise a second pharmacy technician may refuse to supervise a second pharmacy technician if the pharmacist determines in the exercise of his or her professional judgment that permitting the second pharmacy technician on duty would interfere with the effective performance of the pharmacist's responsibilities under this chapter. So I feel like maybe it's kind of captured in there, but maybe it's not as direct as what we're looking for.
But in general, I mean, isn't only technicians allowed to perform duties that are supervised by a pharmacist? So in a sense, pharmacists should already have that built into their work. Like a pharmacy technician can only do what pharmacist is willing to supervise for. So, I mean, it's in a legal sense, maybe this is not clear, but I mean, to me, this is just such a common notion.
Yeah.
Pharmacists absolutely should have authority to say, no, I don't feel comfortable you doing it. Then I don't think the technician should do it. That is, I mean, and maybe it's not clear in legal sense, but I think in a professional sense, that should be very clear, I think, in my opinion, in our profession. I don't know, maybe I'm incorrect, but I think that's been such a long precedent of our practice. Can you comment on that? I mean, I'm like trying to not to put too much spot on you, but you know, I feel like that's just a little, yeah.
So, Sung, I'm sorry, I don't mean to like punt this question. I think it really comes down to probably the interpretation, like the you know, the meaning of the word. So I probably need to like defer to Eileen. I mean, you're absolutely correct that under the law, a technician doesn't have any autonomy, right? It's always under the direct supervision and control of a pharmacist. So I think, yeah, like we might be getting a little too down in the weeds. And like, I think what you're trying to do is like get the conversation back up a little bit higher to like recognize the basic construct of the relationship as it exists.
Right.
Yeah, I think that section though, I think you're right. And I think that probably does cover the pharmacist on duty being able to have the authority to refuse it while they're scheduled.
Yeah, it does, and I think it was always there.
I mean, honestly, for me, I thought this ad was just another layer to give more authority for pharmacists in charge to say something about it, not going back to like pharmacists having supervision. So I feel like this was just another layer to add more autonomy for pharmacists in charge, and why I felt this was actually necessary and helpful. So hopefully that helps, Jesse.
That helps a lot. I'm glad we had this discussion about it.
Okay. All right. So are we ready for vote? Sorry, I knew this was going to be a little long, but sorry that it's taken a little while down the road and with technical difficulties and whatnot. So
I'm so sorry to interrupt. Is the committee looking to ask that staff clarify that nexus in G1 between the technician performing the duties in subdivision A and the duties in subdivision B? There was a little bit of conversation about it, but I wasn't quite sure where that landed. I apologize.
Yeah, and in the motion, yeah, I think I would like to add that piece to work on that language. And
so I would agree with that. So maybe Jig has a motion to work on amending that language for more clarity, and I would second that motion.
We still have a week till next week, so I think we have time for us to add in those clarifications. So let's throw it in there.
So sorry not to be taking over. I'm so sorry. So Jake and Jesse, as I'm understanding, so it's probably recommends that the board pursues statutory proposal to amend BPC section 4115 as presented with clarification on the provisions of the ratio established in G1, something along those lines.
Yes.
Yep.
Okay, we're amending the motion.
Yes.
All right. We're going to go for public comment.
All right, I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or you may simply raise your hand. We're displaying instructions and we'll give you a moment. All right, I'm seeing no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha.
You're welcome.
Thank you, everyone. Okay, so we'll try for a vote here on motion as displayed. And
I think there was someone who chimed in for a public comment a little late.
Oh,
let me.
Trisha.
Sorry about that. Let me. Oh, you're right. It's the same person you saw last time. Sandra.
Yes.
Yes. So sorry. Okay. Sandra, you should be able to unmute yourself.
In response to Board Member Crowley's comment about access and social determinants of care, California, in a recent survey, ranked number 50th, only ahead of Oklahoma in terms of pharmacists per capita. So I just wanted to add that as a point of information for the board. Thank you very much.
All right, this is the moderator, and I do not see further requests for comment. So shall I close the Q&A panel?
Yes, please. Thank you.
You're welcome.
Thank you, everyone. I appreciate your patience and discussion on this. This is a very, very important issue, and we've been working hard for almost a year and a half, going on almost 2 years. So let's see where we go with this, and we'll take a vote on it. Jake, how do you vote?
Yes.
Jesse, how do you vote?
Yes.
And I vote yes, the motion passes. This action will be reflected and considered by the board next week, and hopefully staff can give us some more insight. We might need to amend our motion at the meeting next week, but it is okay. We will go along with that whenever that comes to be next week. So moving on to the next agenda, item 5, discussion and consideration of possible state protocol consistent with provisions of Business and Professions Code, Section 4052.01, as amended in Senate Bill 1259. Members, the board previously considered and established a support position on Senate Bill 1259, which sought to amend Business and Professions Code Section 4052.01 to provide the authority for pharmacists to furnish federal Food, Drug, and Administration-approved opioid antagonist in accordance with standardized procedures or protocols developed under specified conditions. The governor signed this measure, which will become effective January 1st, 2023. As required in the statute, the board and the Medical Board of California must approve, the regulation with consultation with the California Society of Addiction Medicine, the California Pharmacists Association, and other appropriate entities. The statute also specifies areas that must be included in the standardized procedures. The meeting materials provide some history on the initial legislation. In 2014, pharmacists were granted authority to furnish naloxone hydrochloride in accordance with standardized procedures established. Following enactment of the statute, the board, as required in the statute, developed the regulation necessary to implement the statute. The meeting materials also highlight that access to naloxone has changed since 2014, include additional access points for patients to access naloxone hydrochloride, including authority for pharmacists to furnish naloxone hydrochloride to law enforcement agencies and to school districts, county office of education, or charter schools under specified conditions. This expansion has occurred to ensure ready access to this life-saving medication and does not appear to create some of the same requirements as the board's current protocol. The required protocol for pharmacists included in the California Code of Regulations, Section 1746.3, and established the requirements of the standardized procedures established for pharmacists to furnish naloxone hydrochloride pursuant to Section 4052.01. As products are approved by the FDA, and it is appropriate to evaluate the board's current regulation to establish flexibility in the regulation for furnishing of additional opioid antagonists approved by the FDA. I appreciate the efforts of Dr. Gaspar to assist staff with the development of revisions to California Code of Regulations, Section 1746.3. I agree with the recommendation to amend the regulation to both include expansion of the provisions related to the authorized product, as well as streamlining the process reflecting the changes in availability of opioid antagonists in communities. Appreciate your thoughts on the implementation suggested in the meeting materials. I'm happy to work with staff in advance of the January 2023 meeting materials. Members, any thoughts? Okay, we're moving on to public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel, and if any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen, or you may simply raise your hand. We'll give you a moment.
Trisha?
Yes, I was trying to give it extra time since I keep
Oh,
closing it and one person
thank you.
scoots in. So I wanted to be
Oh,
absolutely
thank you.
sure this time, but I don't see anyone. So shall I close it?
Yes, please. Thank you. Just didn't want
You're
to make
welcome.
sure I didn't lose you. Okay. All right. Moving on to next agenda item 6. Discussion and consideration of proposal to establish requirements for pharmacists in charge. Members, the meeting materials include the definition of a pharmacist in charge as a pharmacist proposed by a pharmacy and approved by the board as a supervisor or manager responsible for ensuring the pharmacist's compliance with all state and federal laws and regulations pertaining to the practice of pharmacy. As required by law, and every pharmacy must designate a PIC who is responsible for the pharmacy's compliance with state and federal laws. Also related to the issue, the board also designated a precedential decision that confirmed that a pharmacist in charge of a pharmacy could be disciplined for a pharmacy's violation of Section 4081, resulting from a pharmacy technician's theft of controlled substances without the pharmacist having actual knowledge of or authorizing the violations. As you may recall, one of the strategic objectives established in the board's new strategic plan is to determine if the application requirements for a PIC are appropriate to ensure sufficient knowledge, skills, and abilities for individuals seeking to serve as a PIC. We have previously discussed that it is not uncommon for investigations to substantiate violations where a pharmacist may be designated as a PIC in name only, or the designated PIC fails to exercise appropriate oversight of the operations. Although the egregiousness of the violations varies, there are many instances where such an individual pharmacist ultimately is disciplined, including losing their pharmacist license through the administrative process. As part of the January 2022 board meeting, the board previously approved a draft attestation that would be required to be completed by the proposed PIC as part of the approval process. The language of the attestation is included in the meeting materials. Members also voted to require completion of a board-provided training program for a proposed PIC. Also, as part of the approval process, these changes were sought through the proposed amendments to Section 1709.1. Following the board's action, the rulemaking materials were submitted to the department. As part of its review, the department has suggested additional changes to the language to provide clarification on the attestation statements and process to include the name of the training program in the regulation text. The proposed changes to the language are included in attachment 3. Members, I'm comfortable with the changes being recommended and would appreciate your comments. I would also entertain a motion to recommend again action to the board incorporating these changes, and note a potential motion is included in the meeting materials and displayed on the meeting slide. Members?
Hi, Sung. I agree. I think the language is great. I think this is an important step in the right direction to make sure that PICs have all of the information they need, and we can ensure that they're being trained properly before taking on that position. I do agree that there should be a little bit of time to be able to get this training done, and so that second motion that was included with establishing an effective date 6 months following approval, I think would be appropriate.
Sounds good.
Kind of just a side note, and I'm not sure if this is the right place for it, but I know that a lot of other states do have a minimum requirement of working hours for their PICs. So I wonder if anyone's interested in having that discussion at maybe like a future meeting date.
No, I think that that's a great issue. We should definitely discuss that. I can definitely talk to my Ann and then bring it up for discussion in the next meeting. Jake, any thoughts?
Yeah, no, this is we are going in the right direction here. They are going to be more aware of the responsibilities, the liabilities if any of the laws are not followed. So, yeah, and we definitely want to delay it by 6 months after the approval.
Yeah, I apologize for such a long motion. Well, that's a text over there, but motion is also quite long. So if anyone wants to make a motion on that one, you don't have to read it. Just I think displayed on the slide is sufficient.
Okay. I would make a motion to adopt it as it's on the slide.
Thank you. Thank you, Jake.
I have a question. The one on the slide, does that include that 6-month waiting period? I don't think I see it on there.
That's a second
That will
one.
be a second motion.
Okay, great. So I second that.
Thank you. Okay, we'll go for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen, or simply raise your hand. We're displaying instructions, and we'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you.
You're welcome.
Motion and second, we'll go for vote. Jake?
Yes.
Thank you. Jesse?
Yes.
Thank you. And I vote yes, the motion passes. Okay, as previously mentioned, I would appreciate member comments, but it's already commented. So I think we are ready for motion. If anyone wants to make a motion on the second motion displayed on the slide.
I'll make a motion.
Thank you, Jesse. Jake, do you want a second?
I'll second that. Sorry. Yeah.
Thank you, Jake. I appreciate it. Sorry, it's a small group. Just all right. With that, we're gonna go for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha. With a
You're
motion,
welcome.
a second, and public comment, we'll take a vote. Jake?
Yes.
Thank you, Jake. Jesse?
Yes.
Thank you, Jesse. And I vote yes, the motion passes. Thank you. This recommendation will be considered by the board next week. In the interim, staff will finalize the training as well. So it's 10:30, about 10:30, so we'll take a quick break, unless both of you are just ready to keep going.
I could use a break.
Okay, let's take a 10-minute break. So we'll come back at 10:40, everyone, 10:40.
Sounds good.
See you then. For everyone to come back, and we'll take a quick roll call. See Jig, I see Jesse, there it is. All right. Jig, you're here, right?
Yep, I'm here.
All right, Jesse.
I'm here.
All right, and I'm here. So we're back on the meeting. Moving on to the agenda, item 7, discussion and consideration of discontinuance of business by a pharmacy and potential changes to pharmacy law to ensure continuity of patient care. Members, this will be our first opportunity to discuss the board's requirements for discontinuance of business. I draw your attention to the relevant provisions of pharmacy law noted in the meeting materials. The board's current DOB, not date of birth, DOB process, discontinuation of business process, requires notification to the board. As highlighted in the meeting materials, the current provisions in the law do not establish conditions for continuity of patient care, which I believe is very problematic and appears to contrary to the board's consumer protection mandate. The meeting materials include 2 general areas of complaints received related to the issue, including scenarios where a pharmacy has closed and a patient cannot receive a refill because they are unable to contact a pharmacy to request a prescription transfer, or where a pharmacy has closed and transfer patient prescription refills to another pharmacy, not of the patient's choosing. I agree that in both scenarios, patient care is impeded and patients many times are required to seek a new prescription from their prescriber. I believe the language included in the meeting materials from the board's disciplinary guidelines could serve as a guide to address this issue. Members, there are a number of policy questions included in the meeting materials and on the slides to assist with our consideration of the issue and to determine if changes to the board's current regulations are appropriate, or if in the interest of facilitating continuity of patient care, additional regulation is needed. As we consider these questions, I will solicit feedback from members and open up for public comment. First question, should the board consider establishing requirements to facilitate continuity of patient care in the event of a pharmacy closure? Leave it out there. I can also just start with my thoughts on each question so we can get the discussions flowing. I do in general, yes. I think there has to be some requirements of continuity of care. But granted, I understand that I don't want the board to be too deeply involved in the business decisions and the transactions either. I'm considering that into mind as well. But with that, I do feel that there is some need to have minimum requirements. Members, your thoughts?
I agree with you, Sung. And just in terms of consistency, it would make sense that a pharmacy closure would also have the same requirements as one in which a pharmacy license is surrendered or revoked.
My thoughts are, and obviously the staff has some of the data on this. Are these complaints coming in recently more than before, comparing to like pandemic to pre-pandemic? The reason I ask this is because are these closures due to COVID outbreak in a pharmacy, and folks cannot go to work for 10 days, and those type of things which is required right now by Cal OSHA of all the protocol that everybody follows. And if that's the case, then it was not an issue pre-pandemic, then this was caused by a pandemic. And I personally feel that nothing needs to be done here.
I think this is referring to permanent closure, though, and discontinuation of business. Am I interpreting that correctly, Song?
You're correct, Jesse. This is like when a pharmacy would either just close their doors because of their business decisions, not because of disciplinary reasons. If it is disciplinary related, then there is a provision. But if pharmacy just decides to close its doors, there is nothing that would guarantee the patients who was getting prescriptions at the pharmacy would be able to maintain getting the refills. They had refills remaining. There's no provisions other than a business interest to, sell it, whatever it may be. But even so, it's very inconsistent. It is all over the place. And patients are not able to get their refills that they have. I think they're entitled to get their refills that they have refills on. And I think that they're just not able to get the prescriptions. It could cause delay in their care, treatments. So it's not a common situation, but if you want to speak on to Jake's question, if you have any data, but I do believe there's been some increased discussion on this. Anne?
Yeah, so just in general, this is not a new challenge. I think that, historically there have been consumers that, are have some barriers to receiving their medications because of the closure, and either the pharmacy that closed had already filled the prescription. The patient hadn't picked it up, but it had been billed to the insurance. And so, right, that insurance money's already been consumed because it wasn't reversed. There's also times when a patient potentially needs a refill, or there's a prescription at that pharmacy that the patient hasn't received, whether or not it's been billed. So those are the kinds of things. With respect to the COVID related, I think for those temporary closures, the board kind of already tackled that through their requirements for the temporary notification. So I think that this is really more aimed at when the pharmacy stops business altogether.
Gotcha. Okay, cool. Thank you. Sorry, I was on the wrong track there.
I will also chime in too that, I've had personal experience with this. I think 2 pharmacies in the last year nearby have closed, and it's been pretty chaotic for patients where they weren't given sufficient notice. It's like, oh, we're closing at the end of next week, and that's it. They're being told that prescriptions will be sent to a certain place, and then they're not there. And a lot of patients are frantic, and it's in terms of, serving the consumer, we need to ensure that there's an easy way, at least some minimum requirement that will make them be able to access the needed medications.
Right. Like a minimum. I don't want to get into the business of where pharmacy sells their records or where they can get the prescriptions. I don't want to get in there, me personally speaking, but at least the patient should be notified you can get your refill at this pharmacy, and that has to be somewhat coordinated, and they have to be given a notice or something. Like, unfortunately, if you are so brave enough to go into pharmacy business, unfortunately, you are in a healthcare business and people's lives are affected by it. And so there are some minimum requirements so that those patients can obtain their medications. And not just leaving it up to business decision, I think has to be there, in my opinion. So anyway.
Yeah, no, I think during mergers and acquisitions, anybody in any of those transactions, it's a financial transaction as well. So anybody who is purchasing or acquiring would want to send that message to go to this address, etc. So I'm sure some of these communications are going out there.
I think this is beyond mergers and acquisitions, though. The pharmacies that have been closing by me are not being sold anywhere else. And just this week, a patient showed up to my pharmacy with a piece of paper of someone writing down our address, and they didn't even know until they showed up to the pharmacy. So there isn't a good line of communication that exists right now. And so I think there is a real need for some minimum requirement. This is kind of getting into question number 2, but I'm not sure what the time frame should be. I think patients should be able to notify ahead of time, but I also am just not sure if there are last minute closures that happen and decision makings. I don't know if Anne has more information on that sort of information.
I'm not quite sure I can totally get to what you're looking for, Jesse. I would assume that in most instances, a pharmacy kind of already has a sense that they're going to be closing. And so they probably have an inclination, right? I don't think that you probably make this kind of a decision overnight, but should the committee, or agree that there's something, I think that, language could be developed that provides some flexibility when establishing that time frame so that it does cover those kinds of instances, and then, what that would look like, at least, I don't know, I'm throwing things out, not saying that this is what the language should be, but, within 30 days of, of an impending closure, patients must be notified. If the decision is made within less than that time frame, notification must go out within 24 hours of the decision being made, something along those lines, just for in concept what potentially could look like.
And my thoughts are, if there is a lapse in this, how are we going to enforce for a business that's closed?
Good question.
Do you want me to jump in or
Yeah,
Eileen, I
and
don't know
go
if
ahead,
you want-
jump in.
Yeah, so I think that the board has a number of tools in its toolbox, and I think that you've probably seen some kinds of cases where someone's failed to notify the board of a discontinuance of business. So the board does retain jurisdiction over the license, even when it is canceled. So in those kinds of scenarios, right, doing the investigation and then kind of determining what the outcomes are and, what those violations look like, and then determining how best to respond. I do think that there are potential avenues for the board to explore. I hope that I kind of got to the heart of your question, Jig, and I'm sorry if I misunderstood it.
No, you were right. Yeah, okay. All right, that's good that we have jurisdiction even after closure, especially
Yeah, and I think,
if
yeah,
that
and I think
practice pharmacy in California continue to, yeah.
right. So I think if there's a disciplinary case or so come up for a closed pharmacy, that the persons would still be held liable, like if they were to open another pharmacy or whatnot. So that's probably how it would be guided. Okay, so I feel like we are like Jesse is yes. I think I'm more of a yes. Jig, I'm not sure. You're like maybe.
Yes now. Yeah.
Okay.
Something needs
Okay.
to be
Cool.
done. Yeah.
Okay. Cool. Okay. All right. We're gonna go for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We're displaying instructions and we'll give you a moment. All right, I see no request for comment. Shall I close the Q&A panel?
Yes, please.
Okay.
Okay, so the question 2, Jesse already kind of started. Should the board consider establishing a time frame within which notification to patients is required in advance of a pharmacy closure? I don't have a time frame. I mean, the idea would be that the pharmacy just don't overnight say, I'm gonna stop this business and just close the pharmacy. So, I mean, maybe 30 days, 90 days. 90 days might be a little hard, but considering a lot of people get 90-day prescriptions, maybe 90 days is needed. So I'm kind of like at least hopefully 3 months is my hope. But again, that's, this could also delve into too much numbers and too much details where I'm not sure I'm there either. So,
Yeah, I'm on the fence about this too. I don't know what the perfect number necessarily is. Obviously, in an ideal world, 3 months would be great because that gives patients enough time to see their doctors again if they need to. 30 days is kind of quick, but at the same time, I don't know. I'm thinking of emergency situations, and I'm not sure how often this happens, but being in California, just as an example, I think of what if there's a wildfire somewhere and an independent pharmacy has so much damage that they're not able to
Right.
recover from it and they have to close. Like in that sort of situation, it would obviously be unreasonable to expect a notification ahead of time. And so maybe including some sort of like emergency caveat would be necessary in that for scenarios like that.
Yep. Yeah, obviously we would have to put something in there that covers all the natural disasters, right? Because that's unavoidable and you can't really do anything about it. Happens overnight. I think 2 weeks is appropriate, and I'll tell you why. If a patient is notified today that pharmacy is closing and they notify the board as well, the patient has 2 weeks to either transfer the prescriptions to another pharmacy or to contact their doctor and get new prescriptions sent to another pharmacy. So at least there is a notification process and something could be done about it. So maybe the verbiage could be either electronically or by mail to address on file.
2 weeks. I mean, I guess I should check my mailbox more often, but I don't check mailbox not even like every 3 weeks, maybe every month. So
So I mean, nowadays, I think electronic notification has really picked up in almost every setting I can think
yeah,
of.
yeah,
There's of a touch of a button you can send out. It's so interactive. In fact, I saw a presentation on a new computer system, and they brag about it how easy it is to send a notification out, mass
right,
notification.
Yeah,
But
I still think that a mailed notification would also be necessary because not everyone has access to internet, not everyone has
right,
smartphones, they may not have emails, especially um, patients who are older. I have a lot of patients over 65 who do not have an email address. And so we need to cover our bases for all of our population. I think 2 weeks is a little too short. I will say for someone like myself who has a very inconsistent work schedule, and I know I have a lot of patients who also do, 2 weeks is not enough time for me to be able
right.
to reach out to my doctor or contact another pharmacy. I think
It-
30 days is more appropriate, I think.
Yeah. Okay, so we don't have consensus of time frame, but I said between 2 weeks to 90 days, I would say. So that's where we are, at least for among us. Okay. All right. Public comments?
All right, I'll open up the Q&A panel, and anyone who would like to comment can type comment using the field in the lower right-hand corner on the screen and submit it to all panelists, or simply raise your hand. I do see Mark Johnson with a hand up, and Mark, you should be able to unmute yourself. We'll try that one more time. Oh, so Mark, you're unmuted. Oh, now you're muted. Mark, do you want to try? There you go. You're unmuted, Mark.
Oh, thank you. Mark Johnston with CVS Health. I know the board doesn't generally consider financial considerations, but I wanted to explain the reality of when an independent pharmacist decides to sell his pharmacy to another pharmacy. Quite often they sink their life into their pharmacy, and at the end of their career, the nest egg that they receive from whoever buys their pharmacy is really what they've invested their entire career into. The calculation that goes into obtaining these pharmacies is a big portion of it is retention rate. How many of these customers are going to come to the pharmacy? They measure, there's a factor for how many miles away or how many blocks away from the pharmacy there is, et cetera. One of the factors of retention is how long does the public know? So if you make it a 90-day retention, you're going to erode away enough of the customers that will go out and go to any random pharmacy to the point where that independent will lose a substantial amount of their nest egg. What most states have done is 2 weeks, maybe a month. A month erodes it away too. That way the guy who's worked his whole life can have a nest egg at the end of his career that's sufficient, instead of a pharmacy calculating in, I'm only going to retain 20% because they got letters 90 days ago and there's no customers left by the time they close. So that's the reality. So I thought I would just explain that, realizing you don't generally factor in financials.
All right, the next request for comment is from S. Hill. And S. Hill, you should be able to unmute.
Thank you very much. Interesting conversation on this topic, and I just wanted to throw in a couple thoughts. One is maybe make this notification where it could be electronic or written, but a best faith effort from that standpoint, because depending on how long somebody's been there, the information they give you, or what you get from whether it's the patient or family or relative or whoever else is kind of acting in their behalf, information may not be necessarily great. Or homeless is another one that come to mind. So it might be better to say something about good faith effort from the standpoint of notification, which with whatever time frame you pick for that. Thank you.
All right, and that's the last request I see for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha.
You're welcome.
Okay, so next question is question 3. Should the board consider specifying some of the elements of such notification, the process to request a prescription transfer, where pharmacy records will be transferred to and maintained, or any other options the patient does or should be able to provide input? I think that in general, it's not too detailed for me. I think that, again, I really don't want us to be in the business of pharmacy, but also not hinder too much of business pharmacy. So I really don't want to get in there. So as much as we can to try to be the goal, to be the informed patients that this is happening so that they're not caught off guard and then they show up to the pharmacy. I mean, the whole idea to me, this is that we just don't want someone to show up at the pharmacy and just realize the pharmacy's closed. Or we just don't want someone to call the pharmacy and then phone keeps ringing and then somehow phone's ringing, but yet no one's answering. Or they realize, oh no, the medication that I should have picked up is no longer available to be picked up. So, which all the situations I have heard, seen myself. So, some requirement would be good, just so that we are actually making a difference for the people of California in a positive fashion. So I'm open for thoughts, suggestions on this. I don't have a specific.
Yeah, I agree with you, Sung. I don't think we need to create like a checklist necessarily. I do think though that maybe notifying or giving patients and information on the process of a transfer would be helpful, because a lot of patients aren't familiar with that process, especially if they've been at the pharmacy for a long time.
Right. Yeah.
That's probably the one component I would say would be necessary, but otherwise I agree. I don't want to get into listing requirements.
Yeah, most of them sell the business, and they would put all the components in there necessary, right? Because as Mark mentioned, everything is how much money they get. It's based on retention, et cetera, and all those formulas. So it's in their best interest to provide as much detail as possible, the address, the phone number, and how to transfer or where to pick up next, and update their telephone numbers, et cetera. I think that's standard business process right across most of the chains and community pharmacies. But for independents, usually if they sell it to another independent, the process might be different. But yeah, I don't think we need to get into much details here.
Okay. All right, moderator, we're ready for public comment on this question.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. All right, I see no request for comment. Shall I close the Q&A panel?
Yes, please.
Thank you.
Thank you. The next question, should the board be provided with a copy of the notification? I think that this, I feel strongly yes. So at least we have the record. But I don't know, Jesse and Jig, if you guys have any thoughts.
I don't feel strongly either way, but considering that this is also a requirement for surrenders and revocations, I feel yes as well.
Yeah.
Okay, sounds good. All right. I know that I learned in pharmacy school I should not ask not open-ended question, but sometimes this discussion happens to be. So sometimes it's yes and no, and seems like we're yes. So we're ready for public comment.
All right, I'm opening up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. All right, I see no request for comment. Shall I close the Q&A?
Yes, please, Trisha. Thank you.
You're welcome.
All right. So the next question is, should the board provide expectations on prescriptions remaining in the will call area and provisions for reverse billing? Could get a little tricky, but I do think that there has to be just a simple language at least requiring that if any prescription is not picked up, they better be reversed. That if they're not, then it's that they need to, something must be done, and that's not okay. Because I mean, this is an issue that I come across, not a pharmacy closed, but just a prescription being billed and filled somewhere else, and it's quite a challenge to get that process for patients. So, especially if a pharmacy is closed, I mean, I don't think that our insurance counterparts are good at providing solutions, and pharmacies who are trying to fill these prescriptions for are just left with trying to figure out how to make it happen. And so I think that at least reverse billing has to be in some way described in our proposal, whatever that may be.
It's a standard process, right? The PBM contract. I mean, if you don't reverse something which you're not going to sell, that's fraud.
Yeah, I know.
So
should be obvious, but
if I send a notification, I'm going to close in whatever 30 days, and
better be reversed.
On 30th day, the last day of business, you got to reverse everything out because tomorrow everybody's going somewhere else. But putting some verbiage in it that on last day of business, at the end of business, whatever was not sold should be reversed out of.
Yeah.
I mean, it helps the consumer. If the language is there, then everybody will pay more attention. So it causes less hassle for the consumer. So I see some value in it, but I mean, if somebody's not doing that, gosh, I mean, what are they doing with those claims, right? So.
Oh no, I came across this myself. I mean, the pharmacy closed and the prescription was still billed, but it was just marked picked up, even though they never picked up. And so you're having to figure out, all this stuff. And it's just not a fun place for patients and for pharmacy
So it
staff.
it should be included,
Jessica,
agreed. Should be a given, but yeah.
Sometimes given is not always given, right? So. Okay, we're ready for public comment.
All right, I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen, or simply raise your hand. We'll give you a moment. All right, I see no request for comment. Shall I close the Q&A?
Yes, please. Thank you, Trisha.
You're welcome.
So last question for this agenda item. A long question. There are some pharmacy transactions where a pharmacy sells a portion of its business to another pharmacy. Example, sells a portion of the pharmacy operations related to the prescription dispensing, but maintains the compounding portion of the business. In such an instance, should the board establish notification requirements to patients in advance of the transaction to ensure patient care? Patients are aware of the transition in care. In general, in a perfect world, I would like this to be a possibility, but I feel like this gets really tricky in reality of making it happen. So, but I feel indifferent on this.
Yeah, I mean, I would think that the same sort of rules should apply for the non-compounded prescriptions.
Right.
Or compounded, right? Because you
Right.
could say either or.
Yeah.
Oh, yeah.
Sell the compounded form or whatever, long-term care, whatever it is. Yeah. So I guess anytime like prescriptions are sold, I mean that I don't know that's again I don't know. Yeah.
Here's my opinion on this. It's you are not going out of business. You're selling a portion of business. Your phone lines, everything is going to be there. So as a consumer, if I call this pharmacy to fill my compound or regular prescription or whatever it is, I'll be directed to where I can get care. So I don't see
true.
that this piece is important here.
That is a really good point.
Yeah. That's a good point. So all three of us were like probably not the most crucial. Yeah. Okay.
Agreed.
Okay. All right. Public comments.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. All right, I see no request for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha.
You're welcome.
All right. So there's some agreement here among the questions we have. So, Anne, do you feel like you have clear guidance on where policy direction we are on this, on other questions? So hopefully we can have some proposal consistent with our discussion today.
Yeah, I think you have good consensus here. I think we've got a good starting place. Thank you.
Okay, perfect. Okay, with that, we're moving on to the next agenda item 8. We're almost there. Discussion and consideration of legal requirements for non-resident pharmacies, including possible change to require licensure by the pharmacist in charge. California law requires that any pharmacy located outside a state that provides services into California shall be considered a non-resident pharmacy. Further, this section requires licensure as a non-resident pharmacy. There are no current requirements for pharmacists working in these pharmacies to be licensed in California, even when providing care to California patients. Further, there is no requirement for the PIC of the non-resident pharmacy to be licensed in California. Rather, California law currently just establishes a prohibition for a pharmacist to provide services to California patients if the pharmacist's license was revoked in California. The National Association of Boards of Pharmacy, NABP, establishes model rules for boards to consider as part of its regulation of the practice of pharmacy. Regarding the regulation of non-resident pharmacies, the model rules include a requirement for pharmacists to be licensed in the state in which it is providing services to patients. Further, as the meeting materials indicated, states have a range of requirements for licensure of staff working out of state but providing care to their residents. The materials also provide a few examples of actions taken against non-resident pharmacies. As the board is considering changes to strengthen the requirements of a pharmacist in charge, it is appropriate to also ensure pharmacists appointed as a PIC and non-resident pharmacy also have a full understanding of the law to ensure that Californians who receive prescription drugs from non-resident pharmacies have protections that are similar to those received by resident pharmacies in California. Just FYI, the board has 588 non-resident pharmacies as of this meeting. I appreciate your comments on this issue, including if there is additional information that may be helpful as we consider this new policy issue. I myself feel very strongly of at least minimally requiring pharmacists in charge of non-resident pharmacies to be licensed in California, but open for your thoughts.
I also agree with you, Sung. I think there should be a California licensed pharmacist in charge. Just kind of going through the states here, I know that some states require just any designated pharmacist, but if that pharmacist is solely responsible for compliance with California regulations, then they are essentially a pharmacist in charge. So, I mean, the issue is coming up, and the excuse of I wasn't familiar with California law just isn't sufficient. So I think to guarantee that non-resident pharmacies are complying with the law, I think there needs to be a designated PIC.
Absolutely. Jig, your thoughts?
Yeah, so over 500 non-resident pharmacies, and if we require all the PICs to get licensed in California, um, I'm just thinking out loud, some of them might have been, let's say, out of school for that 15, 20 years. If I had to take the board tomorrow, gosh, I'll do great in certain portions of it, I know. But, it's a challenge. It's a preparation that you need to do while you're working full time. And how many consumers are they serving right now? I don't know if we can get precise data, but got to be a lot. And some of them could be very specialized pharmacy that provides very specific, like specialty prescriptions or specialty compounded prescriptions, etc., that might not be readily available in California or at a price the other pharmacies are. So I'm just on the edge here to bring in a requirement. And I see that there are a few states that are out there that does require, and that's how they protect their consumers. But at the same side, are we going to make it really difficult for consumers to acquire some, this class of medications? And obviously, I don't know all the details what these over 500 pharmacies, all of them are sending to Californians. And also, we don't have reciprocation, right? So I don't know out of the pharmacies that we have examples if there are any reciprocation if they allow them. I know Oregon does, but I don't know about the other states listed. But if there is reciprocation, then some of them would be able to do it quickly and not have that gap. But my biggest concern is, how many folks are being helped right now, and is there going to be a gap? And in the previous agenda item, we were talking about transition of care, and in this, that is my biggest concern, is that transition and all of that. And if some pharmacists in charge are not able to get licensed in time or anything like that, then it can become an issue. So.
Thank you.
I think you bring up good points. I imagine if we were to make some sort of a requirement, we would have to have some sort of delayed time frame for it to allow for either hiring a pharmacist who is licensed in California or allowing time for someone to prepare for it and take the exam.
Right.
But ultimately, there needs to be some person in that facility who is responsible for compliance if they're providing prescriptions for California residents.
Right.
Do we have any information? I'm sure we're not supposed to talk about it on a public meeting on what some of the violations were, or we could talk about in like a general sense, like what really happened. What was the lapse?
Well, from few that was actually in the meeting materials, I think it was just not fully understanding laws and regulations of California, which is why that this is being brought up. And also there's some issues with verifying controlled prescriptions. Are they registered with Cures? Is someone able to check their, are they really able to fully perform their corresponding responsibilities? And I think those are the kind of questions why that we're bringing this up here.
Our licensing process for a non-resident pharmacy, it got to have some verbiage in it that makes them follow California laws.
Right.
Um,
But I mean, there's disparities, obviously, between, you know, if someone is legally liable versus not legally liable, I think that just sends a different signal. So, I mean, if they're all serving California pharmacies, I mean, shouldn't they be held to the same standard? I mean, let's just make sure that we are putting, you know, right emphasis on what is needed to serve Californians, right? And if it's not legally held, can we really make them do and follow the rules and regulations as good as they should? So
Also, I just thinking of like designating a California PIC, and someone please correct me if I'm wrong. I imagine that a pharmacy, a non-resident pharmacy would be able to designate someone who may not be the same person who's the PIC for that particular state. So
right,
you would potentially be able to have someone who's specifically focused on complying with California law, which, as we said, is going to take obviously time to hire, train, study for exams, et cetera. But it doesn't necessarily have to put burden on one person who's already the PIC of that facility.
right.
Yeah, I mean, this one is tricky. We are trying to protect the consumer. I'm just concerned about creating the transition of care, the gap, if, you know, at the end of whenever, let's say if this goes through and, you know, we have a date, and at that time, if there are not PIC that's licensed in California, then some of them would stop sending stuff to California and can create a gap. So that's my biggest concern. And then we would have to deal with something different in terms of consumer complaints. So.
Okay. Good comments, everyone. Okay, so we will go for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel, and if any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. And I do see that Mark Johnson has his hand up. So, Mark, you should be able to unmute yourself.
Thank you, Mark Johnson with CVS Health again. A couple of comments. One, I heard the committee mention reciprocation to California. My understanding with California law is that once you started taking the NAPLEX exam through NABP, like 2 decades ago, that you accept reciprocation. But if you're a pharmacist like me, 55 years old, now granted I've been registered in California for almost 40 years, but if you're a pharmacist like me, you'd have to take the NAPLEX again in order to get California licensed. You couldn't just reciprocate in if you've been a pharmacist for over 20 years. That's a big deal. Secondly, California requires your law exam. So I believe pharmacists would have to fly to California to take the law exam. And that does happen in other states. I texted somebody that I know who's a board member in a different state who is a non-resident PIC. And she said that she spent over $30,000 obtaining licensures from the 15 states or so that require this, which is a gigantic burden. So I would suggest at a minimum, if you're going to go here, look at the Iowa language. It establishes a registration where you don't need full-blown licensure. It's a separate process where you pay a smaller fee. You don't have to take the test. Maybe you have to take that PIC CPE exam that you're requesting of in-state PICs, and an acknowledgement that you've read California law, and you pay a small fee, and then you have a person without having to fly to California and pay all the huge fees. It really is a burden. And when somebody quits quickly, it's an even bigger burden to try to find somebody, and it does lead to patient access issues to find somebody that quickly who's going to be able to be licensed in California. Thank you.
All right, the next request for comment is from Lindsay Gulahorn. Lindsay, you should be able to unmute yourself.
Hi, can you hear me?
Yes.
Great. Hi, this is Lindsay Gulahorn again with the California Retailers Association. We also have concerns with requiring non-resident PICs to obtain licensure in California, and certainly understand the desire to ensure that they have understanding of California law, but we also think that this could impede access to healthcare here in California. Non-resident pharmacies, as you know, provide a number of services to Californians, including providing specialty medications that might not otherwise be available here. So for the reasons my colleague Mark Johnston listed, including regarding taking the NAPLEX and costs for PICs to obtain licensure here, we think doing this would really just put a substantial burden on pharmacists and could reduce access to these pharmacy services and reduce the pool of pharmacists who actually can provide medications to Californians. So would urge the committee not to institute this requirement, and maybe, as Mark suggested, look at registration rather than full licensure. Thank you.
All right, and that is the last request for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. Thank
You're
you for the
welcome.
comments and thoughts. I will work with staff on possible proposal, and then we'll bring it back to where we are, so we can have some further committee discussion on this issue, incorporating some of the thoughts. Just a comment though, I do believe that the test for CPJ is available in other states outside of California. So I just want to make sure, because I heard that a couple times now. I just want to clarify. I don't think it's only California. I know there's like 20 some states that you can go take that exam. So just for the record, I know that that's not just available in California. Okay, moving on to next agenda item 9, licensing statistics. Members, attachment 4 includes licensing data for the first quarter of the fiscal year. During the quarter, the board issued over 3,000 individual licenses and 129 site licenses. The board also issued 91 temporary licenses, 55 of which are for community pharmacies. The board has received over 4,500 applications during this quarter, including 90 applications for community pharmacies, the vast majority of which are non-chain pharmacies. In addition, the board has received 124 temporary applications during the quarter, including 65 for community pharmacies. I highlight specifically the pharmacy workload, as this is one area where licensing times are outside of the board's performance measures. As a committee, we have been monitoring processing times, and I have also been working with Anne on this issue. I'd like to acknowledge the hard work our licensing staff perform each day. The workload is immense, extensive for the number of staff. Staff vacancies and recruitment challenges are contributing factors to these processing times. However, that is just part of the realities of the processing times as well. Staff also experience challenges with applicants that provide incomplete or conflicting information during the application process. Full transparency by entities seeking licensure at the time of application will aid staff significantly in reducing processing times. Any comments from members? Just to add that staff are working every day their best to make sure that we're processing licenses and applications as fast and as diligently as possible, while ensuring that public protection mandate. Moderator, we're ready for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel, and if any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. And we do have a request for comment from S. Hill. S. Hill, you should be able to unmute yourself.
Thank you very much. I appreciate the board's difficulty with the amount of volume and staffing shortages. I think a lot of us are experiencing that on all fronts of this type of thing too. I would ask, maybe consider how to communicate better with the applicants on statuses of license, because I think that's the big question mark a lot of times is where's it at? What's happening with it? Especially if there's delays. Personally, I've used the email function to try to request status and stuff. And I sent several emails and received no response, which was kind of puts me in limbo of what was going on or still going on. So I think better communication to applicants, or if there's a way to see it on the online portal in an automatic fashion, so at least people can see things that are acknowledged, or some kind of workflow-ish a schematic that people can see where it is in the steps of what's needed or what's done or whatnot, and they can check in there. So just some thoughts of how to maybe upgrade process. Thank you.
All right, and we have a request for comment from George Zachariah. George, you should be able to unmute yourself. Try that again.
Trisha, I think he just wrote that out. I do recommend, unfortunately, I don't think we can respond to it.
Okay.
So I just, yeah, my counsel probably would not suggest that. And
Okay.
hopefully, Anne, I don't know if you could note down that, and hopefully we can attend to that question.
Okay.
So we'll move on to the next.
Yes, and that would be Jean Howard. Jean, you should be able to unmute yourself. There you go.
Can you hear me?
Yes.
Okay, great. Thank you. My name is Jeannie Howard, and I'm from the company Dexcom Incorporated. And I would just like to second what the first commenter said, that it would be great if there was a way to check on the status of license applications that have been submitted. And then also if there was, I ran into a little bit of the same situation where I had emailed a couple times asking for status and actually never received a single reply. So I understand how hard it is with staffing shortages, and we're all in the same boat, but having something, even just an automatic acknowledgement would be great. Thank you.
All right, and I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you. Thanks for the comments. And as I said, we are doing our best, and please bear with us. Here are future committee meeting dates for agenda item 10. Can't believe we're almost through 2022. So we are going to see all of you in January of 2023, but I will see most of you next week. So the meeting is adjourned, and I'm sure none of you are sports fans, but I will say go Padres today. So, and with that, the meeting is adjourned. I will see you guys next week.
Thank you.
Thank you.
Bye.